Good afternoon, everyone, and welcome to session 2 of the American Liver Foundation's Liver Health Echo program. Today's focus is MASLD and comorbidities, as well as a program overview. We're thrilled to have you join us today. Change slide here. I'd like to begin with a warm welcome to all of our participants, and we're excited to kick off the session, and we look forward to your engagement. Please state your name and the organizations you represent in the chat. Today, we are honored to have two distinguished speakers with us today. Please welcome Dr. Albert Doe. He's a board-certified hepatologist at clinical associate professor of medicine at UC Davis Health. He specializes in general and transplant hepatology with a focus on steatotic liver disease, including both metabolic and alcohol-associated forms. Dr. Doe is part of the UC Davis Liver Transplant Center, and his research explores metabolic health, liver disease overlap, and transplantation. He's also a dedicated mentor and active member of the American Association for the Study of Liver Diseases, otherwise known as AASLD. And Dr. Doe, you can take it away.
All right. Thank you so much for the opportunity to speak today. Thank you for everyone for logging on. And for everyone who provides care for this very common disease. Thank you for Dr. G, who will also be discussing some clinical scenarios you will encounter when it comes to MASLD. These are our disclosures. I will not be discussing specific comparative effectiveness therapies related to the agents related to the companies with which I have relationships. In terms of learning objectives, by the end of this session, we hope that you will be able to recognize the comorbidities associated with MASLD, metabolic dysfunction associated steatotic liver disease, namely excess weight and obesity, diabetes, hypertension, dyslipidemia, obstructive sleep apnea, chronic kidney disease, and cardiovascular disease. To understand the role of alcohol, endocrine disorders, and medications in steatotic liver disease pathogenesis and progression, to be able to apply MASLD management principles to non-hepatology practice settings, to utilize validated alcohol use assessment tools in your routine practice settings, and then to be able to incorporate secondary steatotic liver diseases into your differential diagnosis in the care of patients with steatotic liver disease. So as an overview of metabolic dysfunction associated steatotic liver disease, or MASLD, this disease represents a very wide spectrum of disease, which varies from generally benign to life-threatening. On one end, we have a healthy liver, which normally contains less than 5% of its cells containing cytoplasmic triglycerides. However, for a variety of reasons, fat can build up, comprising 5% or more of those cells with fat. And that can result in inflammation in some people, resulting in the necroinflammatory phenotype of steatotic liver disease called metabolic dysfunction associated steatohepatitis, or MASH. In some people, that can lead to fibrosis or scarring of the liver. And when that becomes severe, we call that cirrhosis. And in people with fibrosis without cirrhosis, or in people with cirrhosis, that can result in hepatocellular carcinoma, liver cancer. The charge in your practices is to identify those with high-risk findings. In other words, those with fibrosis, those with cirrhosis, those with liver cancer. That is the key sort of clinical practice goal, given how common this disease is. From its original description in 1980 until 2023, this disease was termed non-alcoholic fatty liver disease and its inflammatory subtype NASH, non-alcoholic steatohepatitis. But in 2023, um, there was a completion of a successful international Delphi panel that sought to change the name of this disease and to better organize how we thought about categorizing different diseases that led to fat buildup inside the liver. And subsequently, in 2023, the American Association for the Study of Liver Diseases published updated guidelines about steatotic liver disease. And this figure is taken from that article and summarizes the etiologic and nomenclature framework that we'll be working off today. So on one end, we have classic MASLD, which is the overall disease that we talk about. Whereas on one end, we have fat with no inflammation in the liver, MASL, or also known as isolated steatosis. We have inflammation as a result, leading to MASH. We have fat buildup in the liver from metabolic factors, but also with moderate amount of alcohol intake, termed MASLD. We also have, this is more research is needed in terms of whether pure alcohol associated liver disease is present in the face of metabolic factors, but alcohol associated liver disease is present when excess alcohol thresholds are met. And then we have medications and other diseases that are resultant when fat buildup can occur from other causes as well. And then a small subset of patients have steatotic liver disease from an unknown cause, termed cryptogenic steatotic liver disease, which we won't discuss today because it is thought to be relatively rare. This disease is very common. In one illustrative study of the NHANES database, 2017 to 20 cycle in the United States, it's thought that MASLD prevalence includes 1/3 of the nation's population. And there have been similar studies finding that in the world, similarly, that a similar prevalence has been observed. MetALD, other combination, alcohol, and cryptogenic comprise smaller populations prevalence, but still, when we look at this proportion comprising the world's population, it is still thought to be substantial. And this is, again, the US population, so still substantial when we think about this being a world in absolute numbers of millions of people. And in people with diabetes, this is still even more substantial, that it's thought that 2/3 of people with diabetes are thought to have MASH. So this figure, and there's several others like it in other articles, but this is one summary figure that summarizes the pathways of the three fundamental processes of MASLD: hepatic steatosis, steatohepatitis, and then resultant fibrosis. However, I did want to focus on this part here as most relevant to the consideration of associated comorbidities. So on one end, we have dietary behaviors, fat consumption, and sugar consumption. And here we will discuss diabetes, but there are two main processes that lead to fat buildup within the liver. And so number one is de novo lipogenesis, the process whereby hepatocytes produce fat inside the liver directly through a variety of metabolic and cellular processes. And the other process is exposure of the hepatocyte through blood-free fatty acids. So there are free fatty acids in the blood and the liver is exposed to it. The more the liver is exposed to it, the more fat the liver will take up into its cells. And so then dietary sugars, especially fructose, increase de novo lipogenesis. And so dietary behaviors, specifically sugar consumption, will lead to increased de novo lipogenesis. And so this informs our recommendation for decreasing dietary sugars. But obesity as a comorbidity is thought to be the most important comorbidity that contributes to the development of MASLD. So adipose tissue then can lead to these issues, which I'll mention, but adipose tissue itself has been found to be directly proportional to the amount of blood-free fatty acids, which is present in the blood, which then leads to hepatic steatosis. Additionally, diabetes leads to increased adipose tissue mobilization of blood-free fatty acids, but also leads to insulin resistance and systemic inflammation, and then also increased blood-free fatty acids. Diabetes, by its nature, also is the state of insulin resistance and also increased serum insulin levels. And insulin has been found to be a hormonal trigger to increase hepatic uptake of fatty acids. And so ultimately, obesity and diabetes as comorbidities leads to increased blood-free fatty acids and increased de novo lipogenesis, both of which result in hepatic steatosis. So then it stands to reason that the first step in the treatment of MASLD is weight loss, which is the means to reduce total fat mass reduction, to decrease peripheral adiposity, and thus to reduce blood-free fatty acid that the liver is exposed to. And this is a landmark study from Dr. V.R. Gomez, published in Gastro in 2015, which found exactly that. This was a prospective study of lifestyle modification for 52 weeks of nearly 300 patients who, on average, had obesity. It was found that loss of 5% total body weight led to most patients having improvement in their steatosis. So this is loss of 5%, and this is subsequent improvement in steatosis. Losing 7 to 10% of body weight here led to both NASH resolution and also fibrosis regression in a large proportion of patients, and losing more than 10% led to the vast majority of patients achieving both of these important endpoints in patients who had NASH. And so the challenge, however, is that in this study, only 10% of patients were able to achieve the 10% threshold. In other words, lifestyle modification is difficult. And we know that in our clinical practice of care of patients who we advise to lose weight and they come back and they have difficulty. And so with obesity and diabetes being the most important comorbidities that we think about, there's been increased interest in, incretin agonists, also known as GLP-1 agonists, as potential treatment modalities for MASLD and NASH. And they have been found to be very effective. And so semaglutide, brand names Ozempic for diabetes, Wegovy for obesity, has been studied through most recently published phase 3 Essence trial, finding that fibrosis and steatohepatitis, so this is steatohepatitis compared to placebo, fibrosis compared to placebo, both of which were found to be significant and persistent improvements at 72 weeks. There have been significant improvements. And so just last month, semaglutide, Wegovy, was FDA approved through the accelerated pathway for treating NASH with moderate fibrosis, which is the at-risk group. that research of therapeutics have focused on. And so this is the second therapy that has been approved. Tirzepatide, brand name Mounjaro Zepbound, had published its phase 2 study through the Synergy NASH trial, finding substantial and significant MASH resolution, at high dose 62% compared to placebo. And as expected, it found substantial weight loss and diabetes improvements in other clinical trials as well, but compared to placebo, and the placebo improvement rate is much lower in this case, suggesting that perhaps there's a higher, there's a very high efficacy rate expected. And so it's currently in phase 3 at this point in time. And so other cardiometabolic risk factors in terms of thinking about comorbidities for MASLD, I don't mention it in detail, but there are other studies finding that patients with MASLD have a higher comorbidity burden and also report lower quality of life compared to population controls without MASLD. And it's thought that it's because of the high burden of cardiometabolic risk factors, possibly driven by the presence of obesity and its associated complications. But cardiometabolic risk factors have been found to be associated with MASLD, which is not surprising. But whether there's a chicken or egg phenomenon is a little bit difficult to parse out. But it has been found that a lot of these risk factors do also worsen outcomes and are additive to the prevalence of MASLD, but also the progression. So hypertension has been found to be additive to the other metabolic risk factors for MASLD risk, dyslipidemia in particular. Statins should be emphasized that they are safe in patients with MASLD, including those with cirrhosis, Child-Pugh A, 5 and 6 points that they should be considered and that they have found to be associated with some improvements in MASLD. And so with routine monitoring, that they should be still used, though they aren't recommended to be used as a treatment for MASLD necessarily. In MASLD cirrhosis, it should be noted that even though lipids normalize because of impairments of hepatic function, that there's still a higher risk of coronary artery disease. Obstructive sleep apnea, those with MASLD should be screened for obstructive sleep apnea, which is a ASLD recommendation. And that note that with tirzepatide, moderate to severe obstructive sleep apnea is a separate indication besides obesity and diabetes as well, that this is a separate pathway that could potentially be a way to get this medication for your patients. Chronic kidney disease, MASLD is associated with a 2-time increased prevalence of chronic kidney disease, even controlling for diabetes and for hypertension. And so it's not clear exactly how MASLD could potentially cause it, but further research is needed. Higher MASLD fibrosis stages are associated with higher chronic kidney disease prevalence as well. And again, further research is needed to understand why that is the case. Resmetirom was the first treatment, a thyroid receptor beta agonist, and that has been found to be effective to treat MASH and was the first therapy to be approved through the accelerated pathway to treat MASH with moderate fibrosis. But also it has been found to have effects on dyslipidemia as well. And so it is notable that a lot of these therapies that treat steatotic liver disease also treat associated comorbidities as well. And so should also be considered in these patients. And ultimately, the importance of these comorbidities in MASLD is that the most common cause of mortality in patients with MASLD is cardiovascular mortality. And this was the most important study. There were other signals in smaller studies in the past, but this was a more updated study looking at long-term outcomes in a large Swedish cohort, finding an adjusted hazard ratio of the incidence of major adverse cardiac events higher than population controls. matched population controls, and then also in looking at different phenotypes of patients between population comparators to different increasing risk phenotypes, so simple steatosis, MASH without fibrosis, MASH with fibrosis, and then subsequently MASH cirrhosis. And so you can see increasing risk with a significant P for trend as well, depending on phenotype. So the more severe your disease is, predicted by fibrosis, the higher your risk of cardiovascular mortality. But it is the most common cause of death, even more common than liver-related disease. So I'll turn it over to Dr. G for the first case.
I'm going to quickly introduce Dr. G real quick for the audience here. A moment. Dr. G is a second-year gastroenterology fellow at UC Davis. Dr. G began his academic journey at Johns Hopkins University, followed by medical training at Touro University, California College of Osteopathic Medicine. He completed his internal medicine residency and served as chief resident at UC Irvine, and now brings his expertise and dedication to the UC Davis Fellowship Program. Dr. G, you can go ahead now.
Awesome. Thank you so much. So next we'll begin some cases that hopefully will drive in some teaching points and show some practical examples of MASLD in real life. So the first case is Mr. Little. He's a 55-year-old man. He presents to established care with you. And among his issues, he had been told on the past ultrasound that he has a fatty liver, and he's concerned because of his liver numbers are still up. His past medical history is notable for type 2 diabetes for the past 10 years, hypertension, hyperlipidemia, sleep apnea, and obesity with BMI of 36. He takes metformin, lisinopril, atorvastatin, and he primarily works a desk job with limited physical activity. On review of his laboratory studies, he has elevated liver function tests and also notable for an A1C of 7.6%, which is elevated, and also elevated lipid levels. And you review the last imaging record, which was the abdominal ultrasound, which shows radiology reading of an echogenic liver and a normal spleen size. So there are a few teaching points in this case. So number one, in his case, he does have obesity and type 2 diabetes, and these are very common and treatable risk factors for MASLD, and especially type 2 diabetes. It's very important as it's related to advanced fibrosis. So the goal of this clinic visit would be to risk stratify him to see if he's either low, intermediate, or high risk for significant fibrosis of the liver. One way to risk stratify is to calculate a FIB-4 score. And if he has a low FIB-4, then he does not need a referral for further care. But the big goal of the visit is to see if he has high risk features that require further testing. And so every provider's role, especially him presenting with type 2 diabetes and obesity, we should screen him for MASLD and do fibrosis staging. We have a non-invasive risk score of FIB-4 that our society recommends. And then he has these other medical conditions, including hypertension, dyslipidemia, diabetes, obesity. And if he does have chronic kidney disease, treatment of those conditions can actually reduce his adverse outcome risk and also his liver disease progression. And to put it another way, once again, we want to do fibrosis staging for all patients with steatotic liver disease or steatosis. Whether he has, imaging findings of this on ultrasound and normal liver test, or if he does have elevated liver tests. The ultimate goal, like Dr. Do mentioned, is weight management. And just 3 to 5% would help reduce his steatosis, and 7 to 10% weight loss would improve his fibrosis. Once again, to treat diabetes and hyperlipidemia, even though he does have elevated liver enzymes, statins are safe in MASLD. And then finally, optimize his other conditions. And then every 1 to 2 years, we'll reassess his fibrosis, either by way of recalculating a FIB-4 or getting further imaging. And then if it does progress, there is a certain threshold to refer to a specialist.
Yeah, so then thinking about obesity and diabetes as the most important comorbidities in this disease, I had mentioned that alcohol use in moderation would then lead us to reclassify this disease not as MASLD only, but MASLD with increased alcohol use, also known as MASLD. And so, it is known that patients underreport alcohol use routinely, but then also as providers, it is difficult to obtain a standardized alcohol use history owing to how alcohol is packaged and the variable amounts of ethanol containing within different types of alcohol. And so then there have been various validated measures that are used, some in research, which aren't shown here, but various ones that are used in clinical practice that you should consider incorporating into your practice. And different ones require different amounts of work and have different uses. And so, the one that would be most practical within the constraints of the time that you have, the population that you have, and the goal that you have for your patients should be considered. So, and I'll show you a few of these on the next slide, but the single alcohol screening questionnaire, the SASQ, the alcohol use disorders identification test, the audit or audit C, the shorter form, the using alcohol biomarkers and phosphatidylethanol in your blood is the one that we use in hepatology and in transplant hepatology. And then a standardized drink quantification, which is a sort of more general history, but that requires knowledge about the amount of alcohol that comprises a standard drink. And so this is one image taken from the NIH, one of several NIH resources that quantifies what a standard drink comprises. One standard drink has 14 grams of ethanol within it, but it does require detailed information from a patient regarding how much alcohol they have. So it does require patient report in detail and a reliable historian. And so these are the questionnaires specifically. The NIAAA single alcohol screening question involves one question that you can ask: how many times in the past year have you had X or more drinks? And X is 5 for men, 4 for women. And if they answer yes, then that sort of requires further questioning. And generally, the audit C has been the most well-validated short form questionnaire that you can ask. And that involves 3 questions. The audit involves more questions. And so the audit C has been found to be comparably performing. And so that's why the audit C is more generally used. And it can be up to 12 points, but there's different thresholds for gender. And then further, a positive score for there would warrant you to consider whether unhealthy alcohol use is present. And in severe cases, you would consider whether alcohol use disorder is present. And alcohol use disorder is not something that requires a psychologist or a psychiatrist to diagnose, but it is something that you could consider diagnosing yourself. But it does require more detailed history from the patient itself. The reason alcohol use disorder is important to diagnose is because it would allow you to consider when you would discuss with the patient and recommend alcohol use disorder pharmacotherapy or anti-craving therapies. But if a patient asks for it, it is something that I wouldn't necessarily say that you should follow scores necessarily to offer such therapies if patients are asking for it. And phosphatidylethanol has been found to have high performance for alcohol use. And there's also increasing evidence that is beyond the scope of this conversation that it has been found to be helpful to supplement patient report in identifying MetALD in patients who are thought to have MASLD. But it is high performing with a positive predictive value of 85% and a negative predictive value of 100% with a cutoff of 20. But it is used in our hepatology field as a diagnostic test, not just monitoring, though that is with patient buy-in can be a motivational tool to help support abstinence, but it's not meant to catch patients. And so that expectation should be set clear for patients. But it is something that I routinely mention to patients in the course of my diagnostic testing for patients with elevated liver tests. And so it is not as a major discussion as one would think as it was in years past. And metabolic risk factors interplay with alcohol in so much as it is a two-way street. Patients with alcohol use disorders who have metabolic risk factors, or patients who have alcohol-associated liver disease who have metabolic risk factors. There's been research in both ways. And so on one end, metabolic diseases have been found to increase fibrosis risk in patients who have alcohol-associated liver disease. And so this is one example of a heat map summarizing a large study of UK Biobank analysis looking at fibrosis and the risk of progression to the next stage in patients with alcohol-associated liver disease, looking at specific metabolic risk factors and how strong each of these risk factors predict progression to the next stage. And so insulin resistance has been found to be a strong predictor of the development of advanced fibrosis. And so this is diabetes specifically, suggesting that the presence of diabetes is a strong predictor of advanced fibrosis in patients with alcohol-associated liver disease. On the other end, patients who have metabolic disease, MASLD, higher alcohol use has been found to predict disease, but then also alcohol use has been found to be associated with a higher prevalence of metabolic disease as well, diabetes, hypertension, dyslipidemia, and high blood pressure as well. So again, it's more research is needed about how the two relate to each other, but as comorbidities, they both are interconnected and at times inseparable, and so both need to be treated. And as a paradigm, MetALD in terms of risk is thought to be intermediate to MASLD and alcohol-associated liver disease. It's generally thought that as a liver disease, MASLD progresses slowly in terms of progression to fibrosis, advanced fibrosis, and cirrhosis. Alcohol-associated liver disease is thought to progress quickly. The 5-year risk for decompensation in patients from a population standpoint is thought to be 5 to 15% with metabolic and 15 to 50% in alcohol. But with MetALD, it's thought to be perhaps intermediate 10 to 30%. And then there are modifying factors, cardiometabolic risk. The more metabolic risks one has, the more likely one is to progress. There are certain genetic factors that have been found, and whether or not these increase the risk of other diseases remains to be said. And then the amount of alcohol use has been found to play a role as well. So then I'll turn it to case 2 with Dr. G.
All right, case 2. So we have Mr. Little again, and he returns for follow-up. And this time his PCP has some time and he asks him about alcohol. How many days per week do you drink? And Mr. Little responds, most nights around 2 to 3 glasses of wine with my dinner. How big are your pours? I pour a big glass, maybe about 7 ounces. So does this come about to be 3 drinks a night, 5 nights per week? He says yes. So this is a significant amount of alcohol. It's over 200 grams of alcohol over the span of the week, which is above the threshold of moderate use of 30 grams a day or 150 grams per week. And so a few teaching points in this situation, the AAL-SLD has some definitions of moderate and significant use. It's different between men and women. And so for women, it's anywhere for moderate uses from 21 to 39 grams a day. And for men, it's 31 to 59 grams per day. And the significant use is over 40 grams a day for women and 60 grams a day for men. The fibrosis risk is just 20 grams a day for women and 30 grams a day for men, so around the level of moderate use. And that increases the risk of developing advanced fibrosis. And just like what Dr. Doe was talking about, so alcohol with ongoing metabolic disease causes a synergistic injury pattern to the liver and increases the risk of developing fibrosis, cirrhosis, and the development of hepatocellular carcinoma. And so what should we do in practice? And so in this situation, you can see that the alcohol history, it was asked with multiple questions, clarifying questions to fully elucidate how much Mr. Little was drinking, quantified how many drinks he was having, how many ounces per drink, and then ultimately could calculate the number of grams for alcohol. Dr. Doe mentioned standardized questionnaires that are available and that can be used to quantify their drinking behavior, and then we can also consider the obtaining a PEth level. If alcohol use exceeds thresholds that we previously mentioned, definitely screen for advanced fibrosis. You can use elastography. And in these clinic visits, it's important to diagnose, counsel, and refer for alcohol use disorder treatment. And the main driving home point to educate the patients is that even moderate amount, even drinking that they feel that they're in control or it's not a lot, this could actually really worsen their liver disease.
And it's important to emphasize the point that there have been several studies attempting to identify a lower limit for safe alcohol use. Because they're in cardiovascular literature, there's the general concept of the J-shaped phenomenon whereby moderate alcohol use has been associated with cardiovascular benefit. And so, is it the case that we can identify a low threshold whereby liver is not at risk for adverse effects? And several studies have found that no, unfortunately, there is no safe low threshold for alcohol use at this point. And so to the point that, there is no safe limit that one can recommend from a medical standpoint for alcohol that's considered safe, unfortunately, especially if a patient has another associated liver disease. So shifting gears a little bit, there are a variety of liver diseases that result in fat buildup inside the liver, which can cause steatohepatitis and in the long-term fibrosis, presumably, but are caused by a variety of other conditions. And, Lee published in the Journal of Hepatology an extensive review of these conditions, which I would refer you to if you were interested. But I pulled the table from that article and I underlined the things that I've seen in my practice that you might encounter in the course of yours. And the important thing is to keep an eye out if a patient who presents to your clinic with MASLD or MET-ALD also has these other things, because more likely than not you would treat the metabolic or the alcohol related disease, but these other things might also be contributory factors, other diseases that you might be able to intervene upon as well, which might lead the patient to be at risk for progressive disease. And so those conditions include, these are probably less likely for you to encounter, but for you to be aware of, severe malnutrition and starvation can cause fat buildup in the liver. A person on TPN, owing to a variety of reasons, with short bowel syndrome usually associated. endocrine disorders, so systemic hypothyroidism for one reason or another, polycystic ovarian syndrome, often associated with other metabolic diseases, including obesity, hypothalamic or pituitary dysfunction, usually a person who had received pituitary surgery, growth hormone deficiency, again, usually associated with the pituitary disease, and then drug-related hepatic steatosis and steatohepatitis. I underline the medications that you may encounter patients commonly on, which can contribute: amiodarone, methotrexate, tamoxifen, and corticosteroids.
All right. Our third case is Miss Knight. She's a 32-year-old woman, and she presents to clinic with irregular menses and difficulty losing weight. She asked, "Oh, my gynecologist mentioned fatty liver on ultrasound. Should I be worried?" So her history is notable for polycystic ovary syndrome diagnosed at the age 25 and hypothyroidism on levothyroxine. Her BMI is 33, her blood pressure is normal, and her liver function tests are slightly elevated. She has an elevated triglyceride level and also a slightly elevated A1C at 5.9%. PCOS, hypothyroidism, conditions that she has, and also other conditions like hypogonadism and growth hormone deficiency are associated with higher MASLD prevalence. And so whenever you have a patient come in with these conditions, recognize that these endocrine disorders are risk markers for MASLD. These patients also should have fibrosis risk stratification. And once again, the treatment is the mainstays, addressing the weight, her metabolic risk factors, and thyroid control. Once again, the teaching point is, consider these diseases in our MASLD patients under appropriate settings, and then manage their metabolic risk factors with lifestyle modification, weight management, and optimization of the thyroid and hormonal therapy. And if applicable, collaborate with the subspecialties such as the OBGYN, endocrinologist, rheumatologist, oncologist. And for her, once again, manage her weight, manage her prediabetes, and consider these medications like metformin for her prediabetes and for her PCOS. And our fourth and last case. We have Mr. Painter. He's a 60-year-old man who's on long-term prednisone. He's been taking 10 milligrams daily for the past 2 years for his severe COPD. He asked during this clinic visit, "Could these steroids be affecting my liver?" His pertinent history is COPD, hypertension, and obesity, a BMI of 31. His baseline LFTs were normal in the past, but now they're slightly elevated with the ALT of 72 and the AST of 60. In his situation, it's important to know that long-term steroids, long-term glucocorticoids, and other medications like methotrexate, tamoxifen, and other drugs can cause or accelerate steatotic liver disease. And these medications we see in practice, they are given long-term for the management of certain conditions. And so in practice, if you are prescribing these medications, it's important to review baseline liver tests before starting these medications and get a baseline if the patient does not have that, and then monitor, especially in the first 6 months, so every few months or every 3 months, to monitor the trend after starting these medications. If the LFTs do get elevated, don't just blame it on the medication, but do a thorough workup, including viral, checking for alcohol, autoimmune biliary disorders. And if the patient does have moderate to advanced fibrosis, consider we recommend switching to an alternative therapy because of the liver injury. If there is a question of drug-induced liver injury, there's a website called the NIH Liver Tox Database, which comments on drugs and their known pattern of damage to the liver. And if there is any uncertainty about what's going on with their liver function tests or the medications that they're on, they can be referred to a liver specialist. And the take-home points for this situation is that for patients requiring long-term hepatotoxic drugs, like the ones that we talked about, always check for other baseline metabolic risk factors that we talked about: obesity, diabetes, hypertension. And if the risk of developing MASLD is really high, get close monitoring on this patient or consider alternative medications that are less hepatotoxic or less known to cause injury. And definitely recommend working with the people, other doctors or other providers in these different departments, including pulmonary, rheumatology, and oncology, who commonly use these medications.
And so it's important to know secondary steatotic liver diseases because oftentimes there is something that you can do about these conditions. Certainly, MASLD and MetALD with alcohol require some work and longitudinal care, and that's why your role as patient as providers who see patients sort of more regularly and who have continuity, like your role is likely more important than that of the subspecialist who sees patients sort of less regularly. But these other clinical scenarios causing secondary steatotic liver diseases, they're often pointed interventions that can be done. These are the clinical scenarios that can result in these specific situations that you will likely encounter, which might, hopefully now that you hear them, you'll see, be attuned to sort of picking them up. A patient who has a history on breast cancer, who subsequently is on adjuvant chemoprophylaxis with tamoxifen, these patients can be switched to something else like anastrozole, for example, which is not associated with steatotic liver disease. A patient who has short gut syndrome or other intestinal failure who's on TPN, often has cholestatic liver disease, but it's the steatotic liver disease that isn't sort of generally commented upon. But the composition of the tube feeds can be changed, or intestinal transplant is becoming more common an approach these days on these patients. A craniopharyngioma or other pituitary lesion status post-pituitary surgery causing growth hormone deficiency as part of their pan-hypopituitarism syndrome. And so, an IGF-1 level can diagnose this pretty readily, and then they subsequently can have stimulation testing to formally diagnose it. But growth hormone replacement is the treatment to replace growth hormone deficiency and can pretty readily reverse this deficiency. Rheumatologic diseases such as rheumatoid arthritis or other diseases on methotrexate or corticosteroids. Oftentimes, there are other immune modulating diseases, treatments that can be given to these patients. In general, we know that we don't want patients to be on corticosteroids in the long term, but oftentimes there are other therapies that are available. Similarly, a patient with an dysrhythmia, atrial fibrillation, most commonly on amiodarone. Similarly, there are other treatments available, both rhythm controlling and rate controlling therapies, but also ablation or cardioversion can also be considered as alternative therapies. So patients often, though, have comorbid cardiometabolic risk factors, which can cause MASLD or MetALD in these cases. And so again, more importantly is being attuned to these clinical scenarios in these patients who have MASLD and MetALD. So take-home points, and in summary, MASLD is common, is most commonly directly caused by obesity and insulin resistance. Diabetes, a central driver, is a strong risk factor. MASLD, driven by alcohol on top of MASLD, it increases the risk of MASLD. Even moderate, low or moderate alcohol increases fibrosis risk. Endocrine disorders, namely PCOS, hypothyroidism, hypogonadism, growth hormone deficiency, represent disorders causing steatotic liver disease through distinct mechanism, which can worsen MASLD severity and progression. Certain medications, steroids, methotrexate, tamoxifen, amiodarone, are associated with steatotic liver disease, are considered disease contributors, and should be substituted in those with MASLD, particularly in those with fibrosis, liver damage. Additional take-home points: screen for at-risk disease, especially if they have risk factors for progression, diabetes, obesity. The FIB-4 score is highly sensitive for ruling out advanced fibrosis. A score of less than 1.3 has a sensitivity of around 90%, and can be used to rule out those with advanced fibrosis. But there's other tests like elastography, ultrasound, or transient elastography can be considered. Manage excess weight. Just 5% total body weight loss improves steatosis, but 10% is clinically important, improving fibrosis. Mitigate cardiovascular risk, as is the most common cause of mortality in patients with MASLD. Statins are considered safe up to Child-Pugh A. Treat hypertension, dyslipidemia, chronic kidney disease, obstructive sleep apnea. Monitor fibrosis progression, generally every 1 to 2 years. If they have more risk factors, then every 1 year, but otherwise every 2 years. And then refer to subspecialty care if there's finding of fibrosis or further fibrosis staging is needed owing to discordant findings. The concern for cirrhosis, if there's ever diagnostic uncertainty or if management assistance is needed. But know that all providers play a key role in the care of MASLD, owing to how many patients there are, how complicated the interplay this disease has with other comorbidities and the need for the care of those comorbidities in relation to this disease. So again, would like to thank everyone for logging in. Happy to answer any questions. Though I would like to turn it back real quick to Zach to take it from here.
Yeah, if you guys have any questions for our speakers, feel free to put them in the chat or unmute yourself and ask them out loud. We'll set aside a couple minutes for that, and then we'll move on if there are any questions. That was a really good presentation.
Mary Rudloff, excuse me, asks, with 10% weight loss and fibrosis improvement, does this mean reversal or slow progression? So, steatosis and steatohepatitis is thought to be reversible. You can remove fat from the liver, you can stop inflammation. Fibrosis was classically taught that you were only able to stop it where it was at. It was not able to be reversed. But subsequent studies have found that fibrosis itself is a more dynamic process than we thought. And so it could reverse to some degree. There have been dramatic cases of, someone with F3 going down to F0 even, though from a clinical standpoint, we are unable to definitively say that someone who we labeled as cirrhosis as not having cirrhosis anymore. A biopsy is an imperfect test. And so if we had declared that someone has cirrhosis and we had started liver cancer surveillance on them and monitoring labs every 6 months on them or something, then we would continue to do that even if we did elastography or something in the future and they were found to not have findings suggesting cirrhosis anymore. But other than that, it is the case that fibrosis can reverse to some degree, or at worst, stay the same. Has MASLD at all caused increased liver transplants? Yes. It is currently alcohol-associated liver disease in America is the most common indication for liver transplants, which has replaced hepatitis C in the era of direct antivirals. However, transplants for hepatocellular carcinoma is most commonly due to MASLD. And then MASLD related transplant is the fastest increasing indication for transplant as well. And it's thought that in the next 10 years that MASLD possibly can replace alcohol-associated liver disease, especially given that the burden of alcohol is thought to be potentially decreasing. It had increased substantially after the COVID pandemic. But possibly this was the first year where the prevalence of alcohol-associated liver disease was found to be decreasing. The other challenge of obtaining data is the fact that perhaps there's misclassification in MetALD owing to underreporting of alcohol use. We primarily rely on patient reporting, and so there's challenges with classifying patients with MetALD. So that's part of the issue as well. Liver elastography in diagnostic and prognostic value. So I didn't present the data here because we were focusing on comorbidities, but liver fibrosis is the single most prognosticating finding. And in MASLD, in many liver diseases, but including in MASLD and NAFLD. And so that's why fibrosis staging is so important. So whether a patient has incidentally identified hepatic steatosis or whether or not they have elevated liver tests and then you find hepatic steatosis and it's thought to be MASH, fibrosis is the most important undertaking you can take for these patients to find out how much fibrosis they have. And so then there's a robust body of literature finding that the amount of fibrosis one has, no matter how you slice it, whether you define it by biopsy or FibroScan, also known as transient elastography, or blood-based test, or on MRI, that the more fibrosis you have, the higher your risk of complications, cardiovascular mortality, all-cause mortality, liver cancer development, liver-related mortality. Your risk of mortality increases. There was a very important study looking at the NASH Clinical Research Network database by Arun Sanyal, finding that the risk of mortality, it was a time to event analysis, and finding that the more fibrosis you had, it was stratified by fibrosis. The more fibrosis you had, clearly you can see the time to event curves just spread apart by risk. So yes, the more fibrosis you have, the more risk you are, and that's why you have to stage fibrosis in your patients. Can MASLD return back after liver transplant? If yes, what is the approximate time? Yes, it is very common that post-transplant MASLD occurs after liver transplant. It is very common and it is thought to occur pretty soon after transplant, within a year. However, the likelihood of the development of cirrhosis from MASLD after liver transplant is thought to be low. Unfortunately, in general, after transplant, the most common cause of mortality in liver transplant patients, even separate from whether the disease was MASLD or not, is cardiovascular disease. And so then MASLD increases the risk of cardiovascular disease after transplant. And so, the development of MASLD after transplant is notable because these patients are thought to be at higher cardiovascular risk already before transplant. So all the more emphasizing the treatment, the importance that you need to mitigate their cardiovascular risk after transplant. But more research is needed, unfortunately. It's thought that in MASLD and MASH, that a stage of fibrosis takes approximately 7 to 10 years to develop. So 1 year of fibrosis, 7 to 10 years. And so then, to get to cirrhosis, perhaps 20 to 40 years thereabouts. But post-transplant, fibrosis is thought to possibly progress faster. So that's the other teaching that's important to know as well, in as little as 2 years in some studies. And so that's what informs our recommendation in the ASLD to recommend fibrosis staging in 2 years in patients in general, even though fibrosis staging has been found to progress in such a long time frame.
Any more questions for our speakers? No. So we have run out of time, but There's a few other things I wanted to talk about, but more importantly, I want you guys to see our upcoming sessions here. Our next one is going to be Tuesday, October 7th, same time, 12 o'clock Eastern. I've also attached a QR code here for you guys to quickly register for. And then secondly, I really just want to say thank you to our program sponsor, 89 Bio, for generously supporting the American Liver Foundation's 2025 Liver Health Eye Echo sessions. That is it for everybody.
All right. Thanks again, everyone, for logging in.
Thanks for joining on.